Hi, my name is Wesley Holland. I'm a Yale medical student, and this is our study, Interrupted Time Series of User-Centered Clinical Decision Support Implementation for Emergency Department-Initiated Buprenorphine for Opioid Use Disorder. I have no financial conflicts to disclose, and our funding sources are listed below. So in terms of background, there are hundreds of thousands of opioid-related ED visits every year, and that number continues to increase. And it's not just for overdose that people seek care at the ED. It's also for general health issues and comorbid conditions. And given the stigmas associated with the disorder, this may serve as a primary site of care. And in terms of treatment, buprenorphine is a partial opioid agonist. It's been shown to reduce withdrawal symptoms, craving, relapse, and overdose, and it can be safely initiated in the ED. And taken together, these two things lead to improved patient outcomes. One study found that people who received ED-initiated bup for opioid use disorder were twice as likely to remain engaged in formal addiction treatment 30 days later after discharge. And receipt of bup treatment within 12 months of a non-fatal overdose was associated with decreased mortality, both all-cause and opioid-related. So, why do current treatment practices remain largely unchanged from the historical standard of managing withdrawal symptoms, not the underlying disorder, and referral for addiction treatment? Well, there are a lot of reasons, but some of the big ones are stigma regarding the OUD diagnosis itself and the misconception that medication treatment is not truly drug-free, some legal and regulatory barriers like the requirement of X-waiver training to prescribe bup, and clinician unfamiliarity and perceptions that bup initiation is too complicated and time-consuming, and that many clinicians feel unprepared to provide quality OUD care. And of these, our intervention focuses primarily on the clinician side barriers like being unprepared, unfamiliar, and too busy to provide the best quality care. Specifically, our intervention is a user-centered computerized clinical decision support system, or CDS, designed to address barriers to adoption of ED-initiated bup and guide emergency clinicians through the bup initiation process. And the objective of the study was to assess the feasibility of intervention implementation and to evaluate its preliminary efficacy to increase the rate of ED bup initiation. And the design of the study, it was an interrupted time series with 3 phases: pre-implementation, implementation, and maintenance. The setting was a single urban academic ED, and subjects were adult ED patients identified by a validated computable phenotype as likely to have OUD, and also attending ED physicians practicing at the intervention site who cared for phenotype-positive patients. This is the CDS interface that appears when the CDS is launched by clicking the Embed button in Epic. And the flexible and optional CDS helps clinicians to diagnose OUD, assess OUD withdrawal severity, motivate patient readiness to start treatment, and it also automates several EHR activities that accompany ED initiation of bup, including documentation, orders, prescribing, and referral for ongoing treatment. And just as a side note, just-in-time training was provided as an additional intervention component during the second half of the implementation phase. As far as outcomes, the primary outcome was the rate of ED-initiated bup, and secondary outcomes included the intervention launch rate, rate of naloxone prescription at ED discharge, and referral rate for ongoing addiction treatment. A total of about 141,000 unique patients presented to the ED over both the pre-implementation and implementation phases used for the comparison for the primary analysis, and of these, a total of 906 met OUD phenotype and inclusion criteria. So we can see the primary outcome of bup initiation rate, either administered in the ED or prescribed on discharge, increased from 3.5% in the pre-implementation phase to 6.6% in the implementation phase, which was significant at p equals 0.03. And one secondary outcome, that of naloxone prescription at ED discharge, was also significant with an increase from 6.5% to 11.5% and a p-value of 0.009. And just as a side note again, the significance of the primary outcome was lost only after adjusting for the temporal trend of X-waiver physicians in addition to all of the other covariates in the time series analysis with poison regression, but the significance remained with all other covariate adjustment besides the temporal trend of X-waiver. This time series graph shows the temporal trend of X-waiver physicians I mentioned on the previous slide, and we can see that although the majority of EM faculty had an X-waiver by the end of the pre-implementation phase at 93%, the proportion of unique attendings who adopted the practice of ED-initiated bup was low at only 19.2%. But even though the EM faculty with an X-waiver was only slightly higher at 97%, in the implementation phase, the proportion of unique attendings adopting the practice nearly doubled, 19.2% compared to 32.3%, and that's a p-value of 0.53. Similarly, compared to the first half of the implementation phase, the addition of just-in-time training during the second half was associated with increases in the rate of BUP initiation, the number of unique attendings who initiated BUP, and a significant increase in the proportion of unique attendings who launched the intervention. So taking all these findings together, they led us to hypothesize that the following three intervention components may be both necessary and complementary to increase adoption of ED-initiated BUP. Those three components are user-centered CDS, X-waiver training, and just-in-time training. So our conclusions are the implementation of user-centered CDS to single ED was feasible and acceptable, associated with increased rates of ED-initiated BUP and naloxone prescribing in patients with OUD, and a doubling of the number of unique physicians adopting the practice of ED-initiated BUP. And for future directions, the intervention has now been implemented across several health systems in an ongoing trial to assess its effectiveness, scalability, and generalizability. And here are our references, and thank you for listening.